just to give you a little heads up, we'll be talking about postural instability in aging. And so we have the objectives. So with the objectives, my goal is to kind of give you a sense of what the prevalence of falls are in the community dwelling older adults. At the end, I hope that you're able to describe age-related changes and the elderly population and their impact on postural stability and mobility, and to have an idea of what would be an appropriate assessment and intervention to select for people that may have balance or postural instability problems. So with different behavioral indications for postural instability, first we want to define what might happen if somebody has postural instability. The big thing that we address in physical therapy is the falls. In all of healthcare, we should be very concerned about falls in the elderly population. So a fall is an unintended event, and it usually will result with the person coming to rest on the ground or floor, but they may catch themselves on a chair or a couch or the bed. So it's when they have lost their balance and they end up on another surface. Also, in a clinical sense or research sense, I might define falls as the inability of a person to recover stability independently. Thus, I have to, or a healthcare person has to assist to prevent a fall. So when you work in the hospital setting or even outpatient setting and you're focusing on training balance activities, we're very aware of if the person loses their balance that we may need to help catch them to prevent the falls. So there's important questions that we need to ask regarding falls. So if somebody has a fall that they report to you with your intake information, you want to know things besides did they fall. You want to know what caused the fall. There can be intrinsic factors, which would example would be weakness, or extrinsic factors. The dog leash got wrapped around my legs. The greater number of risk factors that there are increases the amount of risk of falling. So when you take in the inventory from your client, if they have zero risk of factors of falling, they have about an 8% chance of risk to fall. Okay, and we'll go over the risk factors in the next slide. If they have greater than 4 risk factors that we'll identify next, they have up to 78% greater risk of falling. And that was a study by Tanetti that she did in 1988. The other thing you might want to gather is where did the fall happen? So this will help us determine if it may be intrinsic or extrinsic. A study by Kelsey found that women over the age of 75 have a tendency of falling more likely indoors than outdoors. And men who are 75, usually less than 75, usually has a tendency of falling outdoors, but usually near their home outdoors. So it may vary with gender, may vary with age where a person might fall. The other question we want to ask our client is how frequent are the falls occurring? So the more the person falls, the greater chance of falling again. So even one fall doubles the chance of having an additional fall. So very important to qualify and quantify what types of falls are occurring. So CDC just put out some new fall information on their website. They have a very thorough website of facts about falls and fall prevention. And they indicated in 2021 that 30% of adults greater than 65 will fall at least one time a year. Out of those, 1 out of 5 will have a serious injury. So that means about 3 million people were treated in the emergency room in 1 year. Out of those emergency room treatments, 800,000 needed hospitalization. Most often, this was due to head injuries that occurred or hip fractures. So those are the 2 leading injuries that occur with the falls. It varies depending on what site you look at, but 50 to 75% of residents in long-term care facility fall each year. I've read that about 90% of people in long-term facilities have some type of mobility deficit. So this is something that hopefully can be improved upon. I think falls in the nursing home, we can decrease that level of a percentage of falls. The other thing is that the falls are a leading cause of fatal and non-fatal injuries for the older individual. So it breaks down to be about 64 deaths per 100,000 older people due to falls. Along with this drives the cost of falls. In 2015, it was found that $50 billion were spent on the year for fall-related injuries. 75% was covered by Medicare or Medicaid for falls. So projected stats, in 2018, they estimated about 52 million older people were alive. There were 36 million falls and 8 million injuries. Projected statistics for the year 2030 is that we know that the growing of the older populations occurring, 73 million older adults, and they're projecting to be about 52 million falls and 12 million injuries. So this is just off of the steady stop elderly accident, death, and injury on the CDC site, just kind of indicating that the problem is going to continue to grow because the population over 65 is going to double. The population over 80 is going to triple in the next 30 years. This isn't quite a 30-year one. So I put a link for you guys to look at what's on the CDC website. It has falls, injuries, death per state. When you go to the state, you can also get more information of where in the state has higher incidence of falling. So you can go onto the website and look at North Dakota, Minnesota, or whatever state you're from, and you can see if you fall in the average of the number of falls and deaths per year or higher. With a quick look, North Dakota was about average, Minnesota was higher than average in falls. So what are main causes of injury over 65? Here they just show, the CDC shows the pie chart of unintentional injuries and what is the percentage. So 55% of unintentional injuries come from falls. And this is injury-related deaths. So again, very serious, needing to take a better look at how we can prevent this number from rising. Fall deaths have increased 30% from 2007 to 2016. So that makes it about 7 fall deaths every hour by 2030 if we continue to let this rise. So risk factors in older adults, intrinsic ones, usually lower extremity weakness. We talked about history of falls, increases the fall risk. And also when somebody falls, and you guys can even think of this yourself, of when you may have had a fall, you may be a little bit jumpy about doing that activity again if you fell very hard. So older people, when they fall, they may get hurt, they may have gone to the emergency room, they may have been hospitalized, they may have gotten a bruise. They might self-limit their activity because they don't want that to happen again. So fear of falling, we'll talk about in a few slides, but that can have a major cascading event, which limits the person even further. Any gait or balance deficits would be a risk factor. Vision, and as we know, as we age, our vision tends to change, and people also get changes in the vestibular and sensory system. And a lot of times older people will rely on vision, and as it starts to fail, so will you see problems with falls and balance problems. Of course, comorbidities, different health conditions that can impact a whole number of them. Depression, dementia, Alzheimer's, age itself is a risk factor in falls. Extrinsic or environmental risk factors are obstacles that we might trip over, throw rugs or cracks, stairs, slippery surfaces like in the bathroom, or snow on ice in the wintertime, poor lighting, taking medications, especially greater than 4 medications, have a greater impact on your fall risk. Types of medication, if you've looked at side effects of medications, one of the #1 side effects of a lot of medication taken by older individuals is dizziness or impairment of balance. So those are things we might want to look at. So when we look at these lists, which of these factors can we modify and which ones can't we modify? So any input on what might be a modifiable one? I would love to be able to modify my age, but I can't. So we can modify obstacles and lighting and throw rugs. So I'll tell you a little story about throw rugs. Move south, love it. John, love it. Yes, you move south and you don't have to worry about the ice and snow, but you have to worry about the hurricanes and wind and waves. The waves might knock you over. But throw rugs. So I go by my mother-in-law's about, every week, and I throw away her throw rugs. And each week I come back and there's more throw rugs. She thinks they're pretty, but I actually have seen her catch her toe on them, and she puts throw rugs on top of carpet. I don't know why, but I now take them home and throw them in my own garbage can because I realize she takes them out of her garbage. So modifiable ones are things that we can have direct control over, or through education or making changes in home environments. There are some intrinsic factors that are also modifiable. So if somebody has weakness, and a lot of times with balance problems, weakness may come with weakness in hip abductors or weakness in ankle dorsiflexion. And those might be target areas that we work on assessing and increasing strength in also. Fear of falling. Are we ever able to modify fear of falling? We have to be careful with this one because we can't do too many challenging balance activities where the person freezes because they're afraid of them. We might have to gradually work on getting that person's confidence back. We can work on gait and balance deficits. We'll talk about those. We can give proper education on use of assistive devices and if they're appropriate. If a person has a visual deficit, we certainly would want to maybe refer them for an eye exam, because as we age, there's different things that can happen, glaucoma, we can get cataracts, and some of these are modifiable, especially if caught early. Okay, so we'll move on here. So this fear of falling, I want to kind of highlight a little bit, because we can modify this, but we again have to be careful with it. So a person falls, they develop a fear of falling, they reduce their mobility and activity, they get deconditioned, their muscles get weaker, their endurance gets poorer, and they get an increased risk of falls. They fall and the cycle starts over, and it can get more deconditioning, more reduced balance and mobility and activity, and it just goes over and over. So remember, the highest risk factor for falling is a previous fall. So when we look to disrupt the cycle or to modify it, we have to introduce that person back into gradually increasing their mobility, challenging their mobility, increasing their strength, their endurance, and decreasing that risk of falling. So I found this cartoon. This is by Kipper Williams. There's certain modifications we probably don't want to recommend. So I thought this was perfect. I'm lying here permanently to reduce my risk of falling. So she's just not going to get up, but that's not going to correct the problem, right? It's going to keep her from falling again, but it's not going to allow her to do what matters, to get around, to socialize, to get stronger, to stay active in what she's doing. But some people choose to become sedentary because of that fear of falling. So Lancet has several videos. What they did is took videos of cameras that are in a assisted living facility. And we're not gonna watch, I will try to watch one or two of them. They're very short, but I don't want to take up too much time doing it. But what they did is they watched what caused the falls. So the cameras are there all the time. And when they replayed them after somebody had fallen, they went to see what was the cause of the fall. So the first gal is walking with a walker, and the turn causes her fall. And again, education maybe on proper turning might have helped her. The second one, there's a gentleman, he's walking the dog, his wife's a little bit farther ahead of him, and the dog leash crosses in front of him. He thinks he'll be able to adjust, and the extrinsic factor of the dog causes the fall. And so the wife is almost halfway down the hallway and turns around and realizes what happens. This lady is walking down the hallway, and there is a cart in the way. And she sees the cart, but she doesn't adjust to it until very late. And she kind of loses her balance, grabs the cart, but it has wheels, and she ends up falling. And the last one is a woman that is transferring from one chair to her wheelchair, and the wheelchair doesn't have the brakes on it. So just to show you, there's a lot of falls that happen that could be preventable by how we look at them. So I think I won't show the first two are the Lancet videos. I'm going to show the next one, just to show you again how we might be able to prevent a fall from happening.
Jetzt geht es. Ja, jetzt geht er langsam. Jetzt kommt er langsam. Einer müsste jetzt das abrunden, oder? Noch nicht. Wir werden auch einen Vogel. Können wir doch nachher? Also einer muss das abrunden. Nachher. Nein, der ist das. Kilo. Stramm stehen. Wo ist der Kilo? Hey, bitte.
So sometimes falls are preventable. You have to give the men credit that they were showing off their balance, but sometimes it might be a little bit wise to maybe not overbalance too much. So ended up having a little problem when they were on their teeter-totter standing. And you could see a lot of them had walking sticks. They made good choices when they were out hiking, but made a bad choice putting 30 people on a seesaw and then getting the movement that caused the falls. So prevention is going to be very important. So one avenue you can look at for ideas for prevention is the CDC website has, like I said, the STEADY program. And it's a fall prevention startup program for primary caregivers. And it goes through components of screening the person to identify the patients at risk of fall. So if we know the people that have a higher risk, we know if we need to further assess them or do we need to refer them for intervention of some type. If we screen them and they're doing pretty good, we can educate them on ways to prevent falls. There's different programs out there that will do that. Community programs at the senior center or at the fitness centers have programs that yoga, Tai Chi, balance class, stepping on type fall prevention classes. If we find with the screening they're at a risk, we can do further assessment and we try to identify what could be modifiable risk factors that we could do and then go towards intervention. What are effective clinical or community strategies we can recommend? And then always following up with what we're doing with that person. So this just shows this steady algorithm of fall screening, assessment, and intervention. So screening tool, if they answer yes to any of these, then you go to screened at risk. If they're not screened at risk, again, like I said, we talked about education, maybe get them to a community exercise program, reassess yearly or more often if you think is necessary. If they answered yes to the questions about have they fallen or are they fearful of falling, then we can go further to an assessment. And we'll talk about those in the following slides, but I thought the CDC did a nice job kind of showing you what direction to go. When we do that assessment, that will drive our intervention. They have trouble with visual acuity when you test it on the Snellen chart, then we might refer, like I said, for a vision appointment. We'll look at how they're using their other senses to help with balance. So I'll let you guys kind of look through that. And then they always, they recommend a follow-up with the patient after you've done that intervention to make sure that they're continuing to be safe and function well. So number one, we're going to look at things to identify individuals with risk of falls, screenings that you can do. So asking the three key questions that the CDC has pointed out. If they answer yes to any of this, they're at a greater risk of falling. So it kind of puts them over to looking at assessment. Have you fallen in the past year? If so, how often? I often add in, have you had a near fall? So they almost fell. Do you feel unsteady when standing or walking? And are they worried about falling? So if they check yes to any of those, greater risk of falling. they check yes to all three, even a greater risk of falling. The CDC has the Stay Independent questionnaire. It was developed by Rubenstein. And these are a few more questions. And if you see them, they really relate to the 4 M's. They look at the medication, they look a little bit at mentation, look at functional activities. So with the CDC fall risk, you get a point for each of the questions with the exception of the first 2. If you've fallen, you get 2 points. If you use a cane or a walker, you get 2 points. The rest are 1. But they look at how they get around walking, getting up, if they're having trouble sleeping, if they have depression, if they lose sensation in their feet. If they have more than a score of 4 or more, and that as you add it up, it would indicate a risk of falls also. The activity specific balance confidence, or the ABC scale, is made for community dwelling individuals. They answer from 0 to 100, how confident are you doing these 16 different functional activities? They're usually community-based activities. If a person scores less than 60% confident on when you figure out the scoring, they would be at a greater risk of falling. And studies have shown that it accurately classifies people who fall 84% of the time. If they score 80% or greater in their confidence, that's a high level of functioning. 50 to 80 would be moderate, and less than 50 would be low functioning. So again, a way we can see if a person, they answer yes to these particular questions, we can go on and assess with the ABC scale to get more objective measurements. If you have somebody that's not community dwelling, they're more frail, they're at home, or they're in a long-term care facility, Tonetti came up with a falls efficacy scale. And this one has an opposite scoring. The higher the score indicates the more fear falling the person would have. So a score greater of 70 would indicate they have a fear of falling. So this shows the ABC scale. Just to give you an idea of the questions that asked. This is used quite a bit in the clinic. And this is an example of the falls efficacy scale. It only has 10 items to score. 1, they're very confident, 10, not confident. They can choose between those. And you notice that it's more about activities getting around the house versus the community where you would see with ABC. So we did the screening, and our individual was identified as a risk of falling. So now we're going to do further assessment to identify what might be some modifiable risk factors we can take care of. So when we talk about balance, we need to know about how balance works. So postural control or balance is the ability to control your body position in space. So balance or postural stability is the ability to control any displacement of one's center of mass relative to the base of support. So our base of support are our feet on the ground. If we have a cane, that can increase our base of support. A walker can increase it more. But how stable are we keeping our body over our feet? And there's different types of balance. There's static balance, which is just standing in one position, kind of like we test if we did a Romberg test. There's dynamic balance. That's when you're moving the center of mass outside the base of support for part of the activity, which would be walking. Or if I go to reach far and I bring my center of mass over my base of support. And then there's anticipatory balance. You know that your balance is going to be impacted and you're ready for it. So you anticipate it. So somebody throws the ball to you, you get your core stable and you catch the ball. when you go to throw the ball, you know you're throwing it so you can stabilize your body to get the ball to go farther. And the last type of balance is reactive balance. So this is when you step on the snow and the ice and the foot goes and you have to react. You put your arm back to catch you, or sometimes we are unable to respond quick enough to do that. In the clinic, reactive balance could be where the PT nudges the person when they don't know they're going to be nudged. They might be up on a rock or board, or they might be just sitting and you give them a little nudge, and what you're looking for is that they're able to react and catch the balance. Now, it's very important that when we look at assessing and treating balance, that we look at all these component parts. Static balance, if you worked on assessing static balance, doesn't mean that their dynamic balance is good. So they could have good static balance and poor dynamic balance. If we do intervention and we always work on the person keeping their center of mass within their base of support, working static balance, it doesn't carry over to improving dynamic balance. So in order to improve each of these, we need to have intervention programs that addresses where those impairments are. So this young lady is balancing. She decreased her base of support. She's only on one foot, and she's maintaining her balance pretty well there. This gentleman decreased his base of support doing a plank and is able to balance. This is very, very advanced, very fine-tuned balance, okay? So this gentleman, he's a little bit older and he got bored in retirement, and he decided to see how it was to balance on top of one of the high rises in New York City. He has pretty good balance. He's sitting, should have a wider base of support, but he decides to just use the back two legs. So different ways that you balance versus sitting, standing, walking. But here is our older adults. So they're performing an exercise class at the local gym. They're doing static or dynamic balance right now. So they would be moving their center mass over their base of support and beyond it because they're taking steps. So they're working dynamic balance. So if you've ever gone to a local gym that offers senior programming, there's things such as silver sneakers, and there's balance classes. But this is great to promote dynamic balance as long as we do it in a safe environment. And notice, they're all smiling, they're having fun with it. And they're doing step ups, and they're working their balance. But again, this may not be for everybody, so we have to judge what works for each individual. So when we look at balance or postural control, we have to look at the individual. We have to see if they have weakness or range of motion issues or visual issues. We have to look at the environment that they're balancing in. Or is it a solid floor? Is it on soft grass? Is it on a boat? The environment can impact how they're able to balance. And what task are they doing? Are they sitting? Are they standing? Are they reaching? And so when we work on balance, we need to look not just at the impairments of the individual, but how that balance is taking place with the activity in the environment. So balance, postural control takes muscles, takes the nervous system, takes our senses. We'll talk about visual, vestibular, somatosensory, what strategies we use to maintain our balance. So this kind of does the same thing, kind of breaks it out. So when we do more of an assessment now, because the screening came back as a risk of falling, we want to do sensory testing. We can do that by doing a simple test sharp dull. We can test the vestibular system. We can do a Romberg test. We'll talk about the clinical tests for sensory imbalance. I like to call it the foam and dome test, but it looks at vision, vestibular, and somatosensory, and we'll talk about that in a minute. Do a quick visual screen, both for acuity and peripheral vision. Cognitive screening might be indicated if we notice that in our intake eval. So mini-cog or the MOCA or the mini mental state exam are ones that could be done. Then we're definitely going to target looking at strength, especially of the lower extremities that might impact standing balance. And then what motor strategies are being performed by the individual. And we'll talk about what those might be. Posture is going to be very important in balance. That center of mass, the line of gravity should be as close to the joints as possible. And then some different balance tests that we can do, or gait test. So we'll kind of talk about those. So if we look at the components of posture, we have the sensory components, the motor components, and then putting it together, the integration in the central nervous system. So the sensory system of balance, vestibular, kind of senses self to earth, vision, object to object, and somatosensory, self to self. They're all related. They all can be changed as we age. They usually will be declining. So it's very important that we assess these on our older individuals. So when we're standing still and we have our eyes open, a healthy person will end up using their vestibular system 20%, their somatosensory system where they feel their foot on the ground, that'll be 70%, help them with their balance, and vision 10%. But if we change up and we get on an unstable surface, something that's soft and mushy, or you put your patient on a piece of foam, you tend to shift what sensory processes are influenced to help you balance. And so on an unstable surface, 60% will be vestibular, 10% will be somatosensory, and 30% will be vision. So we have to be aware of this as we change the surfaces or the challenges that our patient is doing, that we're also impacting different sensory processes. So the clinical test of sensory integration and balance, it has you do 6 different activities. The first 3 are standing on solid surface, standing on the ground. They change the vision for eyes open, and then they do eyes closed. That's our classic Romberg test. And when you're doing standing with your eyes open, both feet on the ground, doing the Romberg test, we're allowing the patient to use their vision and their somatosensory system. So like the first slide we talked about that they're going to use their somatosensory system the most, okay? So the next one is they would be standing on a firm surface and they put like a Chinese lantern over their head. They conflict the vision. And so you can't use the vision accurately. The eyes are still open, but you can't reference the environment. So this makes the somatosensory system kind of do more of the work. It takes the vision out of it. So what this test is trying to do is see how well those different sensory processes works. So it gets a little bit more challenging. When we get to condition 4, they stand on foam. They stand on foam with their eyes open, their eyes closed, and then with that dome on it. So when they're standing on foam, you take away any accuracy of the somatosensory system. And so for 4, 5, and 6, the person needs to use more of their vestibular system. This condition 5, they close their eyes, they don't have their vision, they're on foam, so they don't really know how their feet are adjusting to the ground. And so very much a vestibular assessment. And 6, their eyes aren't closed, but they have a dome over their head, so they can't reference the environment. So again, looking at vestibular system. So the STSIB or the CTSIB isn't something you're going to get a lot of information about how their risk is, but you're going to identify what they use to help with their balance more. So this is showing all the conditions. Again, 1, 2, 3 is on firm. 4, 5, 6 is on foam. And what they did is they did a study and they looked at amount of sway. So the person should stand there. They may sway a little bit more with their eyes closed. And they looked at younger adults, and then they looked in white, the older adults in red. And they did pretty good. The first 2, they were pretty similar. But when they started to take the somatosensory system out a little bit more, and especially when they were on foam and they manipulated the vision, so eyes are shut or there's a dome over, people that were older had much more difficulty with the balance. And we know with aging, we get a decrease in our visual capabilities, we get a decrease in our sensation. We also get a decrease in our vestibular system. We get a decline in the hair cells in the inner ear that impacts our vision. So what do we learn from doing this clinical test in sensory imbalance is maybe we know where to target our intervention. So if somebody has more difficulty balancing with their eyes closed, our intervention might work more on limiting the lighting or the vision during that time so they can work on using their somatosensory and their vestibular system a little bit more. If people have more difficulty when they're on a compliance surface that reduces the somatosensory system, they're going to now have to use their vision more. And so that might improve how they use their vision to work on balance. And if we take that, have them shut their eyes and have them stand on a foam, now we're making the vestibular system make more of the control of the balance. So we can set up our interventions depending on how they performed on that foam and dome test. So the other part of it, sensory, we have to look at the motor, the efferent part of it. And we can look at different strategies that you have. So if you look at when you're standing and you have your eyes open and your feet are close together and you're doing the Romberg, and if it's not challenging enough, you can do a tandem stance, put one foot in front of the other, the tandem Romberg, and you'll feel that your ankles are doing a little bit of fine adjusting back and forth, back and forth. That's your ankle strategy. So our first line of defense and balance would be doing that ankle strategy. It works really well for small, slow disturbances. Starts distally at the ankle, works up to the hips and trunk. If that is not enough, we have our hip strategy, which works on when we have larger offsets of balance. And it's where our hips go first, trunk will go forward, hips will go, and then the ankles. So exams that we would do for that are one-legged balance or tandem standing or stance on a 2x4. If we don't catch our balance with the ankle or hip strategy, then our last strategy we use is our stepping, or sometimes we'll reach with our upper extremity, reaching strategy. We're going to see how well people do the stepping or reaching strategy. We would do a nudge test, unexpectedly nudge them, usually at the pelvis area, and you're checking to see if that person actually steps. So those would be for more fast, larger offsets of balance. Older people and some sporting events, you'll see a suspension strategy. People that play football they're on the line, they'll squat down to have a lower center of gravity. Older people that feel unsteady will use the strategy of bending their knees and going into a squat to help stabilize themselves also. So this is an example of an ankle strategy, hip strategy, and the stepping strategy. And if we look at the next slide from Shumway Cook, it just shows how the center of mass is actually moving with each of those strategies. So this is showing the woman doing an ankle strategy, the man doing a stepping strategy. So testing motor strategies, we can put our hands on the patient's hip. We can give them unexpected push backwards, and you're looking for them to have their ankles come up with a mild push. You give a bigger push, you see the hip strategy occur. And if you go hard enough, give more of a larger push, you may see a stepping strategy. So we are able to test those. So different influences when you pick which strategy kind of depends on the things listed here. I'll let you read through those. Age-related changes that really can impair these motor strategies: decreased ankle range of motion, weakness of dorsiflexors and hip abductors, decreased sensory function, people with neuropathies, decreased reaction times. So again, some of these are modifiable and we want to key on those. Posture can impact our balance also. So very important that we assess a person's posture. As a person gets older, they tend to get a little bit more kyphotic, a little bit more lordotic forward head, flexion at the knee and hips. So improving posture is modifiable, and if it's not structural, and that's something we might look at. So this is showing some interventions. If we wanted to work on a person's ankle strategies, we might take a half foam roller or a rocker board, either or, and work on the ankles in dorsiflexing, plantar flexing. We want to work on hip strategies. We might go in that tandem stance and have her work on the hip strategy that would be more lateral. We're decreasing her base of support. To work on intervention for stepping strategies, we might take a TheraBand and put it around the waist and have the person lean forward, and then you give the band, it creates them to fall because you kind of give up slack and they have to do a stepping. So those would be looking at sensory and motor strategies. We can also look at functional tests that we can do. Very common one, timed up and go. If a person scores greater than 12 seconds, they're at an increased risk of falling. Quick and easy test, I'll kind of show you that. These are ones recommended by the CDC STEADY program. They have all of these tests and videos and handouts that you can download if you click on the site here. 30-second chair stand test looks at lower extremity strength, but also looks at balance. If the older person falls below average scores, usually it's about 12 sit-to stands in 30 seconds, they're at an increased risk of fall. And then the CDC recommends that you do the 4-stage balance test. So that is, can you stand with your feet together, which is the Romberg? Can you do a semi-tandem? You put one foot into the arch of the other foot and try to stand. You do a tandem Romberg, one foot in front of the other. And if you're able to do that, you go up to a single limb stance, standing on one leg. They found if you cannot stand in a tandem stance for greater than 10 seconds, you're also at a risk of falling. So some assessment mobility ones we can do. So these are, if you can download on CDC, Steady website tells you exactly what to do, what to look for. It gives you the age norms for these different activities. Okay. So if you're at a positive risk, there's some people want to know what test would be best for individuals. If you have somebody that's a limited community walker, they're usually better to do the Berg balance test or the Berg balance scale or the tug or the 10-meter time walk test. If they're community walkers, sometimes these are too easy. So using the mini best test or the dynamic gait index and still get their walking speed. So I'm not going to talk too much about the Berg balance test, but this kind of shows the overview of it. It's 56 points. But if you fall less than 36 score, you're 100% fall risk. And each point dropped after 54 increases your fall risk by 7%. So if I had somebody that screened that they had a fall risk and I did a further assessment of the Berg, I could get more information of what might cause them. So this is different items that we do with the Berg assessment. Notice there's some very similar items that we talked about from the Steady screening that we've done. The mini best test, we don't have time to go into talking about this, but it is Faye Horak took and looked at all the different balance tests, and she took the best of the best tests. What were the best stats for giving information about fall risk and balance? And she put them into what's called the best test. Well, the best test took 45 minutes to do. So she made a mini best test, which is the best test of the best test. And she made sure to cover those items that we talked about earlier. What are 4 types of balance? Anticipatory, reactive, static, and dynamic. And she made sure that those 4 categories were covered in the mini best test. So there's more information. She has made a website that's free to use that has videos and information about the mini best test. And so gait changes change with aging also. We won't have time to go in with all of those, but you can read through it. But when we take the gait speed, if people walk slower than 1.0 meters per second, or especially if they go less than 0.7 meters per second, they're going to be at a much higher risk of falling. So easy to lay out a 10-meter time walk test. You measure the time between the middle 6 meters. This gives them time to get up to walking speed and slow down. And so a great way to measure walking speed. And this just indicates walking speed on a fit person should be above 1.3 meters. And then it shows those key areas where you can get increased risk of falling. So everybody should be able to increase their walking speed as to get across the street or parking lot. So we usually test comfortable walking speed and actually fast walking speed, seeing if the person's able to increase about 30% above their comfortable walking speed. So dynamic gait we won't talk about, but that would be for your higher level person. You could refer them to physical therapy for that. And then just to finish with other interventions besides what we've already talked about is the Steady program kind of gives you an indication of interventions for those. But if it's strength, maybe go to a physical therapist or OT, or have them go to a community exercise program to work on that. So different balance strategies we already discussed for impairments and for motor and sensory strategies. If you do functional task training, they should incorporate both static, dynamic, anticipatory, and reactive. Start easy and challenge the person. Always use a gait belt, and education, education, education. So evidence shows that you need about 50 hours to improve your balance. That would be 1 hour, 2 times per week for 26 weeks, or 3 times per week for 8 to 10 weeks. So balance isn't something that's going to change from one session to the next. It's going to be more over time. So I'm just going to end with some information off of the study website that just kind of in a larger font shows you recommendations that you can do. And I think we've talked about a lot of these: environmental, working on increasing the risk, intrinsic risk, extrinsic risk factors that might occur. And then it just shows a couple different balance activities that you can do to work on dynamic activities. And this is just showing safe home exercises that a person can hold on to the counter, or hold on to the steps, or hold on to the chair and do these safely. So I have my references there.